Good afternoon, everybody. I'm Dr. Anthony Levinson from McMaster University, here with co-founder of iGeriCare, Dr. Richard Stramko, geriatrician par excellence. And we're here today for our 33rd iGeriCare live online event. And today's Thursday, April 14th, 2022. And today's topic is one that Richard and I are both very close to, which is around caring for cognitively impaired people in healthcare settings. Particularly, I think we're going to talk about some of the challenges around treatment in the hospital setting in particular. In Canada, hospitalization rates are about 65% higher for people living with dementia than for those without. And another impressive statistic is for those 65 to 79, the stay in hospital is about twice as long if you're living with dementia than without. So people with dementia going to hospital more, staying there longer, and a trip to the hospital can sometimes be very, very stressful for both the person living with dementia and their care partners. And so we wanted to talk a little bit about what some of those challenges look like and how to be prepared as best as possible. So Richard, thank you again for joining us today.
It's my pleasure to be here. Good to see you again.
Great to see you as well. So let's start with the scenario that is maybe the planned visit. So somebody's, the person with dementia has to go in for a test, a treatment, or a planned procedure like an operation. What are some of your suggestions, I guess, for family caregivers to kind of help that situation go as smoothly as possible?
Yeah, I mean, it always helps to have a plan and rehearse as much as possible what you expect to take place. And obviously, things are a little bit different if somebody has just very mild dementia or mild cognitive impairment versus more moderate to severe. Um, for the people that can retain information, explaining to them what's going to happen and preparing them for what you'd expect to take place and why they're going to be there is often very helpful. Understanding that they'll need, if they do go in hospital, to kind of be reoriented perhaps more frequently than people would if they did not have cognitive issues. So getting prepared with either a clock in their room or understanding the dates and the times and why they're in hospital and what is happening to them. Because if you forget that, or if you can't retain that, then just waking up in a hospital bed or finding yourself in a hospital room can be very disorientating and frightening in that sense. Helping the team, a lot of times we'll note this at the bedside where people will write instructions to healthcare providers. So as nursing shifts change and the family is not able to be there, at least people will understand, how perhaps, that they have a diagnosis of cognitive impairment or dementia, how they would like to be addressed, what their preferences are, and any other general instructions about how they like to be treated or specific issues. Hearing and visual impairment are quite an issue. So if people do have hearing aids, you want to be able to send people into the hospital so that they can hear their care providers as best as possible and also see what's happening. Because your hearing and your vision also are very important to orienting you to your environment and being able to understand what's taking place from the healthcare team on a day-to-day basis as things can change quite considerably. Making sure that everybody's belongings are labeled. So I'm always kind of a bit torn on the hearing aid issue because they're so expensive and they go missing so frequently in hospital. So you have to be very careful that if they are around, you want to make sure that they're labeled and you want to look for them all the time. Other alternatives, if somebody's going into the hospital and for the first few days where there might be lots of confusion, is sending somebody with a pocket talker, which is a device where people can actually, it looks like a Walkman, old school, I know, but they'll have headphones and they'll have a cable to what looks like a Walkman, but it's actually a microphone. And so you can turn up the volume and it amplifies the sound coming in through this device right directly. And even if people have severe hearing impairment, they'll still be able to hear what's happening. And then any clear documents around goals of care, like if there's any escalation that's required. So sometimes when people are sick in hospital, you need to provide additional supports. Like if let's say their heart was to stop suddenly, understanding would they want interventions like CPR where people get compressions on their chest, or whether they would want a breathing tube placed down or sent to the intensive care unit for escalating levels of care. If sometimes if you had an advanced dementia and you were suffering from that and you had to go into hospital for whatever reason, perhaps you would not want escalation of care because it would not be in keeping with what your goals and values are. So the more clearly laid out what your values and expectations are, the better. And then also clearly communicating anybody that's involved in their care team. So sometimes in the hospital, they'll just take down next of kin, right? Which might just be a spouse, or it might just be a son or a daughter. But if there are more people that you want involved, then leaving the list of those names so people know who to communicate with and how best to reach them is also helpful as well.
I think trying to involve the person living with dementia, if they're going for an overnight stay, to kind of help to pack the materials, like pack the bag that they're bringing. They may want to bring along things that are familiar or comforting to them, and obviously it's a balancing act, because if you're going in for a very short time, you don't want things to go missing that are important to them. And I share some of your concerns about the pros and cons of things like expensive hearing aids or prescription glasses, things that sometimes, along with dentures, seem to go missing in the inpatient environment. But if it's for a shorter visit, and there can be family or friends who are able to accompany the person, then I think the more things that can help to reorient and keep the person less anxious in this new environment, the better from that standpoint.
That makes a lot of sense in terms of understanding what your most likely length of stay is going to be. Like not everything is 100% predictable, but that's a good point that you bring up. Like some people are just going to be in for a morning and out in the afternoon if it's a day procedure, and we're trying to discuss more the lengthy hospitalizations or perhaps a bigger operation that somebody might go, like a hip replacement or something like that.
And I think sometimes for the longer stay, you talked about sort of giving staff somewhat of a sense of the person. And there's like a short form document called All About Me that was produced by the Alzheimer's Society, and has information, personal details, family details, as well as often includes a summary of kind of allergies or medical history, likes and dislikes. So if the person's going to be in hospital for a procedure and it's going to be for a few days, then sometimes something like that, just to, if a family or friend can't be at the bedside, might actually help to communicate a bit more about the person's values and preferences if they're struggling to communicate at that point, depending on how advanced the dementia might be. Let's talk a little bit about some of the unplanned visits, because I think that's more, I guess, what you and I often see, somebody with a cognitive impairment who develops an illness that requires hospitalization, but it wasn't planned. So what are some of your, I guess, advice on this? One of the questions that we did receive as well was, a person sent in the question about what are the actual causes for what are the main causes of the high rates of hospitalization. So we talked about the high rates, almost double for people living with dementia. What are the most common causes for that?
It's a great question. And it depends a little bit on the severity of the dementia itself. So if people have very mild dementia, they're more likely to go to hospital with the same issues that other non-cognitively impaired individuals will experience. So really common reasons are infections like a pneumonia or a urinary tract infection, um, just regular heart disease, because as you get older, your risk of dementia increases, but so does your risk of all the cardiovascular diseases and chronic kidney disease and everything else. So other reasons to come in, lung disease like COPD exacerbations, and then our heart failure would be very, very common reasons, as well as skin and soft tissue infections.
You mentioned as well, having to go in for a hip operation or something like that. So I would say mechanical falls are
Mhm.
also one of the things that happens, and whether the person has a fracture and may or may not require, surgery, there's still often people who have had a fall and come in for assessment, or they've sustained some kind of muscle, brain, or tissue injury related to the fall, even if they don't necessarily, if they haven't fractured something.
No, that's a great point. And so, we've talked about the mild people, and then as dementia progresses, usually as well, there's some increase in what we call kind of frailty, which is like the cognitive impairments getting worse. You're getting a little bit more susceptible to infections. Your nutrition might be not as good, and your mobility or walking starts to decline as well. And that's kind of this kind of increased falls risk that you're describing as well, and fracturing that happens. And then you'll get to a more severe stage where people have really significant cognitive impairment, and they might be completely dependent for all of their kind of functional care. People need to help them with bathing and getting in and out of bed, and they may lie in bed for long periods of time. And that's really associated with a high risk of pneumonias, in particular aspiration pneumonias, where people will swallow their food into their lungs, or liquids into their lungs, and cause a chemical irritation there. And then just as the immune system kind of starts to fail, there are lots of urinary tract infections or skin and soft tissue infections as well. And so you'll see people that have severe dementia get a lot of hospitalizations for those reasons closer to the end of their lives.
I think the other thing that accounts for it is the impact of an infection on somebody living with dementia can be much more profound than somebody without cognitive impairment. So sometimes the person with dementia may have a urinary tract infection, and that might trigger a episode of quite profound confusion and delirium, whereas a younger person with the same infection might not have that same reaction. So I think that partly accounts for the increased rates of hospitalization. I think, as you said, it tends to be the risk factors for dementia of age are also the risk factors for developing other illnesses that take one to the hospital. But I think dementia also confers vulnerability to frailty and having a more challenging reaction to a potential infection, and sometimes it's that will lead to the increased rates of hospitalization as well.
I think it's probably worth. Do you want to touch on delirium a little bit now? I think probably a good time to
Sure.
mention it. So, we've talked a lot about this, the slow and steady decline in memory and thinking or executive function that's associated with dementia, whereas delirium is an acute confusional state where you notice a change in somebody's ability to process. They're very inattentive, so they can't sustain or focus their attention on something for long periods of time. They may be looking around the room, or when you ask them questions, they can't follow through on a sentence or finish a sentence, and they won't necessarily be able to follow commands. It fluctuates. So within the same day, you'll see somebody in the morning and they'll look quite lucid and be able to have a conversation. And several hours later, you'll come back and they'll might be very confused. And then really concerning for people to see are the emotional disturbances or perceptual disturbances. So people may get very sad, they might get very anxious, they might get very angry or irritable in terms of an emotional disturbance. And then from a perceptual disturbance point of view, they may see things that are not there. So having hallucinations or illusions where patterns are on the walls, and that can be quite disturbing for people, and even kind of being paranoid or delusional in some cases. And so I think that is a major issue because of the greatly increased risk for people that have dementia to develop the delirium, but also because of the plan in place to try and prevent delirium amongst those people. So some of the issues we touched upon with respect to the preparation side of things, well, if you know you're going to have to educate that person, or sorry, intervene for the person with dementia in terms of the frequent orientation, making sure they can see, making sure they can hear, trying to have a quiet environment as much as possible, maybe through using earplugs, getting them up out of bed early in their hospitalization to get them walking around, making sure, if possible, through medication or non-medication interventions to keep them sleeping, and making sure that they're well nourished. There's good scientific evidence that if you can do that to people, you reduce their risk of developing delirium quite substantively.
And the one other piece that's really important as part of that is also trying to identify and treat the most likely underlying cause or causes. So while you're doing those other measures that you just described, look to see if there is a source of infection and treat that infection, or look to see if there's any kind of electrolyte abnormalities, the person's sodium very low and something needs to be corrected there. I think this is another area, though, in terms of the tremendous value of the family or friend care partner, is to provide reliable information to the hospital team to be able to say, this is not what my loved one is normally like. So I think because there's such a large range of different stages in dementia, and people with more advanced stages may have uh, periods where they have a lot of trouble communicating, or potentially certain behaviors or perceptual abnormalities that overlap with the delirium. It's incredibly helpful for a family member to give us that information and say, no, this is not at all what they were like. Last week we had a great time together. We had lunch where they lived together. They were able to so this period now where they're very paranoid and they seem to be seeing things totally uncharacteristic, and it's come on very quickly. And because I think sometimes when we're just in the hospital setting and taking a snapshot, I feel like we as health professionals are often a bit quick to judge that, oh, this must be this person's baseline function. They've been like this for a week now, when they are, probably just need a longer period of time to recover from delirium, or the underlying cause hasn't been found and they're still delirious. So I feel like the family can provide so much helpful information on what the person's, baseline day-to-day function is usually like.
I think, yeah, I mean, what you're saying is so important. And I think what cognitive specialties can do more of is just the education for other healthcare providers and family members to really appreciate just how diverse experience are of people living with dementia, right? And it's really unfortunate that sometimes people will have a very narrow idea of what it is and what it looks like. And so, as you're saying, they'll say, oh, this person has dementia, they're confused, they're bad. Whereas, like, exactly as you said, they were playing golf last week and they needed a little bit of help with their taxes and a little bit of help with cooking, but they were a very functional person versus somebody that's has end stage disease that needs to be treated completely differently. But when you have it's the unfortunate part about having that umbrella term.
Do you recommend, because some people will talk about having a a bag prepared just in case of emergency, a so-called like go bag, for even for an unplanned visit. At a minimum, I think there's maybe some value in having a list of what you might bring. But I'm just wondering what you recommend for people.
Yeah, no, that's what I would say. It's pretty, it's for me, it's impractical, like um, to just to have a bag completely packed all of the time. And I would say it might depend on how close of a caregiver they have and how functional their caregivers are. So um, I think a list or a bag, and a list seems a bit more practical to me if you have a functional caregiver around to say, this is my hospitalization list. These are my goals of care list, and it's easily visible on your fridge somewhere so that people know exactly, and then here's my contact list. So I think if you had a list of things to pack, a list of like a document about your goals of care and a list of your contacts ready to go, you're further ahead than 98% of all people that end up
Yeah.
in the hospital, you know?
Let's talk a little bit about what the impact of hospitalization is on the person living with dementia. I would say, especially during the pandemic, but maybe always seems like a very, very stressful time for people and caregivers, especially at some points in the pandemic. Caregivers have had limited access to be kind of at the bedside, but I think we do see frequently people with, say, moderately advanced dementia where being in hospital itself is very disorienting for them. So they may not actually have delirium, but the experience of being in an unfamiliar place, and as you said, that it's a very some elements and some areas of the hospital may feel very chaotic if they're in an emergency department and there's IV poles beeping all over the place, and people kind of moving around. What are some of the things we can say about, I guess, the impact of hospitalization, and maybe if there are any strategies that caregivers can do to help?
Yeah. I mean, the biggest thing is just abrupt changes in somebody's overall life trajectory. So when anybody is in the hospital, they lose quite a lot of their muscle function quite quickly. If they're ill and cannot move around, then their muscles will get slightly smaller or atrophy, and they lose their function very quickly. That's particularly true for people that have this kind of frailty to begin with, or sarcopenia, which is this age-related loss of muscle function that tends to happen to a lot of people and can be accelerated in certain groups. So if people are doing well, they might hit this hospitalization, and then their functional status related to their mobility, or if they've had some sort of insult to the brain, like a delirium, and it's not going to get better, then that could mean that the discharge planning is quite, in addition to the acute things that you were talking about that they have to deal with in the hospital, it really impacts often what they're able to do after that hospitalization. So frequently, the associated time that they spend additionally in the hospital is related to figuring out how you're going to get somebody home safely. And now let's say that they need a walker and they didn't need one before. How are you going to get that into their home? They can't bathe themselves anymore because they're too weak. So how are you going to arrange personal support workers to come into the home to support them with those issues? If they can't remember or think as well, then perhaps they need things like medication or reminders. So there's a huge impact. And sometimes people will require a full shift. So they were living independently in their house before, and now they need to be moved to a retirement home, or sometimes even they'll need to go into a long-term care facility because the degree of supports they need are so substantive compared to previous to compared to before they came into hospital. And then just stuff like the biggest thing I'll see people struggling with is the inability to communicate their needs. So they're not acutely confused or delirious necessarily, but they won't be able to say what they're feeling. And so sometimes pain is manifested differently in people that have dementia. They might wince or have tears coming out, or just withdraw to touch, but they won't be able to tell you like, I feel pain. And that obviously can increase their suffering. Or they won't be able to say, I'm hungry, or I need to eat right now. And so their tray of food might come in and be placed beside them, but they might not cue somebody in that they need help to actually feed themselves. And they might not remember that they need to keep up with their fluid intake. And then other things that might happen are like kind of wandering around the ward because people are a bit disoriented. And so occasionally, if people are wandering or they can't communicate their needs, they might get a little upset or agitated. And you can redirect somebody and acknowledge how they feel by saying, hey, I'm sorry you feel that way. Maybe let's go get a cup of tea, or do you need a drink of water? What do you think about what's happening in the sports teams or something like that? Something that's of interest to them. But occasionally people will receive medications to sedate them or make them easier to care for. And those medications can be quite harmful and even cause a delirium. So again, it's families and the people with dementia communicating what their baseline level of function is and what their needs are, and what the best ways to communicate or facilitate communication are to avoid episodes where people are just going to reflexively get bad, let's say antipsychotic medications that they don't actually need and which confer a lot of risk.
As we talked about right at the start, too, not only are people living with dementia twice as likely to get hospitalized, their length of hospitalization is longer, and the longer somebody's in hospital, the more the risk of acquiring what's sometimes called a hospital-related harm. In other words, you may get an infection in hospital. You may lose some of your muscle mass and coordination and have a fall in hospital. So you may through your own you may get dehydrated even in hospital if you don't have like an intravenous and you're not able to keep up with your fluid intake. So all of these hospital related harms are more likely to occur to people living with dementia and more likely to occur for people in the hospital for longer. So that's, again, I think just another really important role that family friend caregivers can play to kind of for their loved one, recognizing that it's just not always feasible to be at the bedside all day every day with a family member. But I think the role that family members play as advocates, and I will say, I think at this time during in Ontario, the sixth wave of the pandemic, but there are staffing shortages in many healthcare systems across the country. And so I think the role of the family caregiver may be even more important, because I think sometimes the staff are doing their best in the hospitals, but they're fewer staff for more patients, and more patients who may have very high needs. So I think we would always say, if you can avoid hospitalization, try. And if you can keep it as short as possible and, try to support the person getting back home to reduce the duration of hospitalization. Most people don't stay in the hospital longer than they would want to anyway. So
I would say oftentimes when you're admitting people to hospital, it's not like this wasn't like a 1 minute history of shortness of breath. Like that does happen. People come in for very acute reasons, but quite frequently, let's say somebody has heart failure, it's like, well, yeah, my legs have been swelling over the last week and I've slowly been getting more short of breath. And, I've been coughing more at night when I lie down. If people can pay attention and get their chronic diseases managed appropriately and have enough contact, with their care providers, then a lot of these admissions can be avoided. So that's the other upstream thing, is like the better you can take care of yourself and tune into your chronic disease management needs, the better the more likely you are to avoid hospitalization.
I would say I was attending the Canadian Geriatric Society conference recently, and there is a lot of talk about improving standards of care for people living with dementia in hospitals. I think because because of the rates of admission and length of stay, to really try to do better within our hospital systems to provide better service for people living with dementia. So.
It's funny too, because I tell the residents this, like, the bowel and bladder function is so incredibly important, because people that get constipated can lose weight and can actually become delirious. It also can cause urinary retention, which worsens your risk of getting a delirium, or can cause delirium as well. And so, even stuff like that, where it's like I order and find so many bowel and bladder problems just by ordering an abdominal X-ray, getting a bladder scan. So there, a lot of these standards of care are also very simple things. Hard to implement, but in theory, they're quite simple. So,
Yeah, and I think we are seeing more in hospital settings something that's called order sets, where you might standardize certain procedures or orders, or at least facilitate the physician who's conducting an assessment. We have delirium order sets, so it will outline, oh, here would be a typical set of investigations and management considerations for a person with delirium. And so I think sometimes those kinds of things might help as quality improvement initiatives, and it'll be interesting to see if there might be more of those that are trialed, to see if they might help improve the quality of care for people with dementia in hospital. Let's go to some of our viewer questions and comments. Why are urinary tract infections apparently such a high risk for delirium?
It's a very interesting question. The answer is we don't know. There's some sort of changes that happen within the brain when people are delirious that are resulted to alterations in level of neurotransmitters, inflammation, and stress. So that could be elevated levels of things like cortisol or other adrenergic hormones, which kind of increase people's heart rate and blood pressure, and can also contribute to this. So we don't know where on the continuum all of those things are, but certainly a urinary tract infection can cause inflammation. It's much higher risk of getting delirious if you actually get that infection in your blood, or have more systemic infection as well. So there's something about the inflammation that throws off something in the brain, potentially altered neurotransmitters that can lead to this confused state.
And I would say that it is a bit of a harbinger of somebody most likely having a cognitive disorder, or will go on to have one within the next 5 years. So when as I was saying before, if a young healthy person without an underlying dementia has a urinary tract infection, it's very rare that they would develop delirium secondary to that. But it is actually not that uncommon that we see it in the setting of people who may have mild cognitive impairment. Not every urinary tract infection will trigger this type of urosepsis or confusion, but it is certainly not an uncommon cause in people with cognitive disorders.
Yeah, usually I'll say if you have a strong brain, it takes a strong insult to cause somebody to be delirious. So a young person could get delirious, but only if they're so sick, usually, that they end up in the intensive care unit.
Yeah, the bacteria has spread to the blood and caused that sort of bacteremia or sepsis. Yeah.
Whereas somebody that's profoundly cognitively impaired may just take a tiny dose of the wrong medication, or a change in their environment, to tip them off into a delirium. So there's a big spectrum.
There's a really helpful comment here that says volunteers in hospitals are so important. Joseph Brant Hospital has many programs that help ease dementia patients' confusion. There's the hospital elder life program, or the help program. I think the lack of volunteers during the pandemic just like the limitations on family friend care partners at some points. I think I would agree those have had, had an adverse impact on people with dementia. And so hopefully when this pandemic is over and volunteers are also functioning at capacity again, I think that's an excellent comment and makes a big difference to help reorient people and just ease some of that confusion for people and provide some another voice of advocacy at times. So um, there's a question. Do you have any advice for someone with, I think this is going to be constant ear ringing? Is it part of dementia? It's written as a contract ear ringing, but I think it's probably somebody with ringing in their ears, which is sometimes called tinnitus. Is that a part of dementia?
No, would be it'd be very atypical. I've never heard of it. Although I'm sure neurodegenerative diseases can present in a whole host of ways, but I'd say very, very uncommon to have a dementia present as tinnitus, and usually you'd require assessment by an ear, nose, and throat surgeon to rule out various causes, or potentially a neurologist. But
yeah, I guess the tinnitus is also very common, and dementia is also relatively common. So it's not unusual that there might be some overlap, but it's probably not causally related to a particular condition. But the one thing that is worth keeping in mind, there is a hearing loss is a risk factor for both. So I think if you are having tinnitus, it's definitely worth getting your hearing checked, because it can be associated with various types of hearing loss. And even if the ringing is, like, often tinnitus is notoriously challenging to treat. So you may not necessarily be able to treat the tinnitus, but you may be able to provide some kind of correction to help with any associated hearing loss, which might also be protective in terms of dementia. So worth getting looked into. And so I guess that would be the main advice.
Yeah. Don't take too much aspirin, because that can cause tinnitus.
Yeah. And there are some medication treatments. And again, if you can access a referral to an ear, nose, and throat specialist or an ENT, they're typically the people that would do a more, a more in-depth assessment of tinnitus, because it's more often than not related to kind of the ear part of things rather than the brain part. So this is I think an interesting question. The question as posed is, can a patient refuse to go to a home if their doctor and family wants them to go? Now, I'm going to assume that that's a question about going to a long-term care home, but I think we can phrase this even related to this current topic of, well, what if somebody needs to go to the hospital, but the person with dementia is refusing to go? And then I guess this other scenario is, can a person who's in the hospital, who maybe you mentioned earlier, Richard, maybe there's been some changes in their functional ability and they now need more supports than can be provided at home, but they want to return to their home and don't wish to go to a long-term care home or wherever it's been deemed that it makes sense for them to move to. So what if these scenarios where patient's refusing to come to hospital, or patient is refusing to go to, let's take a long-term care home as the example.
Right. So, I mean, this is a larger decision making in dementia kind of theme, and often we'll refer to it as the capacity or ability to make decisions. They can be around things like hospitalization, healthcare decisions, financial decisions, and kind of personal decisions like where you're living and things like that. So often it's a continuum, and just because you don't have the ability to make decisions in one area, let's say finances are really complicated for some reason, and you own 14 properties and cannot manage those properties anymore, is a lot different than, hey, do I want to get an operation or take a medication for a certain disease, or where do I want to live? So it's fluid, it changes all the time. You could be delirious and incapacitated, and then 3 months later you could be have capacity again. It's decision specific. So as I said, healthcare, finances, personal decisions are all very different. And even if the person doesn't have the ability to make decisions, you usually try to err on the side of maintaining autonomy, dignity, respect. The only time where you intervene if they are not capable is really if the risks are so great. So you're talking about somebody wanting to go into the home. Well, if somebody has rotten food in their fridge and they haven't eaten for a month and they're constantly leaving their stove on or setting fires in an apartment building where other people will reside, then usually across provinces, there are laws where you can intervene and override that person's decision making, say that they're incapable, and put them in an environment that's more suitable for them to live. So it's the Healthcare Consent Act in Ontario, and there's various iterations.
Yeah, every province, and really the principles around informed consent and the various domains of consent and capacity, they're pretty analogous across the country. Most of the provincial kind of healthcare consent act, and they usually the provisions also determine, well, if the person does not have decision-making capacity in this realm, who is entitled to be their substitute decision maker. And there's usually, stipulations that come with being a substitute decision maker. And that's where it's very helpful for family members to try to understand the values and preferences of their loved one. And, there's different scenarios here as well. It's very challenging when somebody is, right on the edge of being capable. And I think those are some of the most challenging scenarios that family and friends have, where, the person is just barely still capable of making that decision, wants to go home, but there are not necessarily all of the safeguards in place for them to live safely, independently at home, but they're still in that position to make that decision. And in the Ontario context, if there's a disagreement about it, you would probably actually get an independent capacity assessor who specializes in the particular determination of accommodation or determination of lodging field, because sometimes it might be pretty contentious. The family might be saying you need to go and live at a long-term care home where you can get supported, and the patient, who may still have capacity, is saying, I do not want that, I want to return home. So in those cases where the healthcare team is unsure, having that kind of formal capacity assessor come and do the assessment with respect to lodging may be important. And you have to be prepared to live with an answer that you, as the family member, may still be struggling with, like, how are we going to make this work safely? So
it is pretty tough, because you come across all of these scenarios in day-to-day practice, and there are some people that are just like, I don't want to deal with mom or dad anymore, like they need to go to a home. Then you talk to the person there, and they're like, they're pretty with it, they understand things, they want to go home, they want to live with risk. And I think that's part of it too, is that if you pictured like a 42-year-old alcoholic that continues to drink, is not cognitively impaired, but partakes in activities that are very harmful to their behavior and has multiple bad things happen to them as a result, you never remove their autonomy, right? And so the same kind of rules have to be at play. Just because someone has dementia doesn't mean that they can't make decisions, and just because you're old does not mean that somebody can take away your right to willfully live at risk. We all take.
And I think that's where, as well, even if the person has lost their decision-making capacity around lodging, you want to still try to involve them as best as possible in decisions. Same for personal care decisions. Ultimately, it may pass to the substitute decision maker, but you want to try to capture the values and preferences of that person as best as possible, engage them in the process, even if they no longer have the ultimate decision-making agency on it. But it's definitely challenging. I want to finish off. There was a very thoughtful comment that was sent in. I'm just going to read it, and then we'll have maybe a brief discussion about it. So it was a comment sent in, and it goes, why does the medical community still use the MMSC, that's the mini mental status exam, or the Folstein, and the MOCA, the Montreal cognitive assessment test, to detect dementia? I knew I had dementia when I was 51, when I lost my job in accounting, but the only testing offered to me was the MMSC, which I had no problem passing. And yet I immediately forgot things I put in the refrigerator or in closets or cabinets. I had to insist on seeing a neurologist when I was 55. They just wanted to monitor my symptoms, which meant a 15-minute appointment once every 6 to 12 months. It took 4 neurologists to finally find one to take my symptoms seriously. She looked over my entire past medical history to find I'd had a stroke, not a brain bleed, when I was 35, and 3 TIAs sometime since then. I was diagnosed with probable vascular dementia at 63. So that's a full 12 years from this person noticing the cognitive changes. I'm almost 65 now, and I'm pissed that it took me so long to get a diagnosis. I spent several years thinking I was losing my mind, even attempted suicide at one low point. Today, I advocate for timely diagnosis and function as a writer for Dementia Alliance International and co-host a peer-to-peer chat group on Mondays called DAI Canadian Social Support Group. I regret all the years I lost trying to figure out what was wrong with me, but have decided to move on because my life did not end with my diagnosis. In many ways, it has really just begun. So I want to thank you for sharing this. I wish things had been different for you, because it sounds like it was an incredibly frustrating 12-year journey to diagnosis. I'm going to say Richard and I have the experience sometimes of working with people with maybe more rare causes of dementia or slowly progressive ones, where this kind of time from symptoms to diagnosis does sometimes occur, but it's often a very frustrating journey through the healthcare system to go to multiple people. And I wanted to share this story, one, because I think we recognize, or many of us in the medical community recognize, that we need to do a better job around dementia diagnosis and communication of the diagnosis, but also probably screening in various settings like primary care. And I think the other things that I wanted to share were just the work that you've done, this person's done on setting up the peer-to-peer chat group. So for those of you who might find something like this helpful, the DAI Canadian Social Support Group through the Dementia Alliance International may offer this kind of support group. So I don't know, do you have any other comments on that, Richard?
Yeah, I mean, with the initial question being, why does the medical community still use those tests? I think, one is because they're easy to administer, and they provide, scores that have pretty, not like very reliable and valid cutoffs for people with certain types of dementia. The problem is that because they're easy, somebody might have a superficial understanding of them and apply it in a blanket setting to everybody. Whereas there are people that, let's say, have a behavioral variant frontotemporal dementia where they'll have almost no changes in their MMSE or MOCA to begin with. And then there are also people that, if you have a really, it's called like a high cognitive reserve, so you have a high baseline intelligence, like I said, strong brain, you can withstand a lot of insults. And so you could notice something happening, and let's say you were a university professor or something, and you can't give your lectures in exactly the way you could, but you can do everything else in your day-to-day life. People might not take it that seriously, whereas something could be happening seriously. The thing that really strikes me about this situation is if that big degree of social and occupational dysfunction, like losing your job, is such a big deal. And I've seen people that have lost their jobs with severe untreated anxiety that resulted in cognitive dysfunction and more psychiatric illness. But there's treatments for that. In this setting, I would always, let's say the MOCA and the MMSE were normal, there's additional, more complicated tests, neuropsychological testing, where they're harder tests and longer tests. But because they're harder and longer, they can pick up those smaller sensitive changes. And so when somebody has had such big changes to their social life or work life, I will always send them for those tests, and then certainly additional imaging. Like this person would definitely
Yeah.
get an MRI to look.
I totally agree. I think it's to your point and to the original question, the MOCA and the MMSE are not diagnostic tests. They are screening tests, and they're designed as screening tests. And, I think if we had somebody like this come to our practice, of course, we're going to be geniuses in hindsight. But I think if we have somebody who is a highly trained professional who at a relatively young age of 51 is, reporting difficulties doing their work for cognitive reasons, that aspect of the history is much more telling than performance on a sort of useful but blunt screening instrument. They're not diagnostic tests. So I think the history is very telling, proper investigations, listen to the person. So it is always a bit disappointing for us in the medical profession, I think, to hear about somebody having this kind of frustrating journey. And we certainly like to think we would have done better.
This is part of the reason why we do this, though, right? This is our 33rd event, and the reason we enjoy this is the advocacy component and getting the word out there so that more people can understand how diverse people's experiences, presentations are, all of the different types of dementias and how they might present. So the more we can put the word out there, hopefully things continue to change. And as an anecdote, the number of medical professionals that I see using the term neurodegenerative now in the last 5 years, I feel like has increased exponentially. And even being aware of the delirium order sets and stuff like that that we were talking about, or like those things have changed a lot. So I'm hoping that now if this person presented, they would not have the same experience, or at least the likelihood of this happening is much, much lower than it would have been in the past. So
maybe the second neurologist gets it right,
right,
7 years earlier, kind of thing. So,
and you can't be perfect. Certainly there's other doctors that have diagnosed stuff that I didn't catch, like, so it's totally fair. But again, I'm sorry for this person's experience. That sounds really frustrating.
Yeah. And I guess, but they're obviously quite resilient and have, tried to move themselves into an advocacy role. And, I think there's a lot of families, people living with dementia, families, family care partners who really benefit from the kind of peer-to-peer support. So, good job by you turning this unfortunate experience into something to support others.
Absolutely.
Well, I want to thank you, Richard, for another wide-ranging and excellent live event. iGeriCare was developed with support by the Canadian Centre for Aging and Brain Health Innovation, powered by Baycrest, the Jerris Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, our local Alzheimer's Society Foundation of Hamilton Halton, and our great team at the Division of E-Learning Innovation. Just a reminder to click on the donate button in the top right corner of the iGeriCare.ca website to keep the magic going. And there is a survey that is pinned at the top. As you can see, this is our first YouTube live, so you can watch these live events on YouTube, Facebook, and on the iGeriCare.ca/events. Really look forward to any feedback from the surveys or via email. And we'll see you again probably in about 2 months. So thanks for joining us today.
See you later.